All right, my Yuja account is acting up, so I'm doing this on Screencast-O-Matic. But anyway, it limits me to 15 minutes. So I'll try to be quick. Febrile seizures. These are not to be concerned about, and we have to remind parents that, a child can develop a febrile seizure at any age between the age of 6 months and 3 years, and more commonly less than 5 years. Not very often this happens, but if a child gets high enough fever, they can have a convulsion or a seizure. We definitely want to be treating them with Tylenol, and then if they end up, having a long enough seizure, which doesn't usually happen with this, but we can give Ativan or Valium. But regular seizures, or like epilepsy, this is a common thing for kids. Again, putting aside the high fever or infections, and some kids can get meningitis and end up with a seizure. That is something a little bit more concerning to look into, right? So we do worry about seizures in kids. Other things that can be problematic are brain tumors, or problems from environment, like a smoking, and maybe mom was smoking or using alcohol during pregnancy. This is a couple other reasons. We've talked about seizures before, but there's things called absent seizures. They look like they're daydreaming, and sometimes they just kind of pass out. And then there are partial, generalized, tonic-clonic, or grand mal seizures, and then epilepsy, a chronic disorder of seizure activity. So sometimes kids can just have one or two seizures, and then they no longer ever have them again. So this is something, obviously, if we have a kid that has a seizure or two, we definitely want to be having them seen by their providers, by their pediatrician. But these are kind of the types of seizures. Tonic-clonic, of course, they get stiff and they do some jerking movements, and that's why they're called tonic and clonic. Put them in the rescue position. Do not try to put anything in a patient's mouth or stick anything in their mouth to worry about their tongue. Very dangerous to do that. Just put them in the side-lying rescue position and try to keep their head safe from banging on anything. Like put a pillow under their head. That's the best thing you can do with a kid. Okay. Oops, I think my thing skipped a page here. So I'm going back to, this is the tonic-clonic emergency treatment, rescue position. Again, protect from injury, make sure they have an open airway. Think about the ABCs. And then note the time and how long the seizure actually lasts, because that's important. Cerebral palsy. Not sure if you guys have seen any kids with cerebral palsy, or otherwise known as CP. It is a group of disorders often affecting movement, posture, muscle tone, caused by damage that occurs to the immature brain. Often it's an anoxia, a lack of oxygen for a short period of time during either birth or labor and delivery, or in utero. They often have spastic movements, hypertonicity, stiff, rigid, difficulty walking. They almost use, like when they're crawling on the floor, they almost use like a worm-like movement. They often have emotional outbursts sometimes. But the big thing here is a lot of physical therapy, and often have to have, they do go to school. Kids with CP go to school. They get special sort of teaching, because they often have delays in growth and development, especially development, and need a lot of one-on-one care. really difficult for parents as they're growing up to kind of manage all the different things that they need to manage. Okay, spina bifida, also known as myelomeningocele, failure of the neural tube to close. So you'll see this neural tube protruding through the lower back. They do a surgery to close it. There are many forms of this. So the child can have, just a myelocele or a meningocele, and there are different levels. So every case might be a little bit different, okay? But the goal is to protect that fluid-filled sac that's visible outside of the body until they have surgery. So making sure we're putting them in a prone position on an open diaper and protecting that area from any injury. These kids are often going to have loss of sensation or weakness below the level of the sac or the myelomeningocele. And you can see like this child is going to be using a walker. They will close it up, but again, if they have paralysis or they have weakness or loss of sensation below the level of the sac, then they're going to have lifelong difficulty. Meningitis we talked about in class already, but again, children can get meningitis, and you could see that it can cause swelling. It can cause changes in their brain. They can get it also from otitis media or upper respiratory tract infection. So those are a couple different ways because of their eustachian tubes going right into their, right near the brain. They can end up with meningitis easily. There's kind of systemic effects here resulting in fatal meningitis and how it spreads so quickly to the other parts of the body and the organs. Causative organisms are usually flu, pneumonia, meningitis itself, and then meningococcal, of course, is the culprit. Fever of unknown origin would be one of the signs, and lethargy. So look at the top here with the infants and how they're going to show their signs and symptoms, and then the bottom here is older children and adults usually get a stiff neck, a headache, and fever, some vomiting, sensitivity to light, whereas an infant might have cold hands and feet with a fever, refusing to eat, vomiting, high-pitched moaning or crying, don't want to be held, and some neck retraction because they're arching their back to try to relieve some of the pain. There's some other things there. Of course, here's some more signs and symptoms, especially of an older child. Nuchal rigidity, the Kernig's, positive Kernig's and Brodzinski neck signs. And then, of course, diagnosis and treatment are going to be similar to what we've already talked about in class with adults. We take a spinal tap. We also just do some cultures, blood cultures, urine cultures, chemistries, and we would probably start them on a good antibiotic right away. Within 1 hour of diagnosis is important. And you could see a couple of different antibiotics here that for young babies, and then older children, penicillin or chloramphenicol, or, if they're allergic, we can do ceftriaxone. Lots of fluids, those are important because kids will get dehydrated from the vomiting. Fluid replacement is important. And then follow up on their neurological function. Do they have any increased ICP? Remember that we always are monitoring for that with meningitis, anything affecting the brain. High risk for spread of infection, so we keep them isolated until they've been on antibiotics for at least 24 hours. And then, here's some nursing care, making sure we're giving them enough fluids, do daily weights and I's and O's, and monitor IV replacement, their IV sites. Kids with meningitis could have seizures, so we're going to put seizure pads on the beds. Think about maybe visual or hearing deficits if they came from an ear infection. Hydrocephalus, if they're young enough, they could get hydrocephalus. Trauma to the brain, you know, when kids either fall or have injuries, bicycles, you know, crashing into things, we're going to be looking for concussions, contusions, or lacerations or fractures. Big thing with those, again, too, is the increased intracranial pressure inside their brain. So we often, when we have a kid with an injury, we're going to do head CT, MRIs to try to identify any injury, bleeding inside the brain. We talked about that. And tumors, of course, if it's not from an injury and all of a sudden they're exhibiting balance deficits, stumbling, falling, headaches, we can look for tumors. Want to find out the cause early on. And then, of course, increased intracranial pressure. The big thing, the earliest indicator of changes is a level of consciousness change. So are they alert, right? Or are they having any cognitive issues? Those are important to be assessing. And then lack of painful stimuli is abnormal, so this should be reported to the providers immediately. Vital signs, you know, are the vital signs stable? We're always monitoring for shock, right? That's an important thing for us to be monitoring for. Pupil size and reactions. So we want to look for sudden fixed or dilated pupils. That's an emergency. All right. Muscle strength, asymmetrical movements and tone changes from one side to the other. We're always assessing one side to the other side. Tremors, twitching, spasms, flapping. Are they flaccid or are they hyperactive muscle movements, neuromuscular? So these are assessments we can do by assessing strength and movement. Posturing, we talked about decorticate and decerebrate. These are a little bit different for kids. And then shaking baby syndrome. It's basically a coupe or contra-coupe injury because the skull is banging off, the brain is banging off the skull bone, causing injury to the brain itself. And this is why babies have very sensitive brains because they aren't fully, and their skulls are not really that hard. So their brains can easily be damaged with a shaking type of a syndrome. Lastly, Reye Syndrome. This is something we don't see. It's very, very rare these days because people do not give their kids aspirin. But when we do see it, we just have to be aware of it. It usually follows a viral illness. And someone have given the child lots of aspirin, but it's basically an encephalopathy. It could be a very serious condition causing swelling in the liver and the brain, affecting mostly children, teenagers recovering from a viral infection. Most commonly, the flu or chickenpox is the culprit. And then we've also noted that they were given aspirin. And aspirin comes in a lot of products, right? Like Motrin, sometimes will have aspirin in it. You have to really look at labels and talk to parents about really checking labels. The signs and symptoms of Reye's will be fever, decreased level of consciousness, and hepatic dysfunction. So again, we might be looking at their liver functions in this case. Prognosis is good. So that's... there really isn't any treatment. We wait for them we give them fluids, take away the aspirin that we've been giving them, and then usually it's a self-limiting kind of a, prognosis, again, will be good. But we have to make sure we identify it so that they don't have permanent liver damage. Okay. That's it for neuro on pediatrics, and now I'm going to do a separate video on musculoskeletal, just some common musculoskeletal.